SBU is the Spina Bifida Association's new online education program. Our goal is to bring the world's best care providers and resources directly into your home. SBU is the only free webinar series dedicated solely to the educational, employment, social, self-advocacy, and health needs of people with spina bifida. We hope that you will enjoy this presentation, Neurogenic Bladder, Birth to Late Childhood, Surgical Management and Procedures, and that you take the time to complete the evaluation at the close of the presentation. This presentation is brought to you through an unrestricted educational grant from Hollister Incorporated.
Good morning, and welcome back to Spina Bifida University. My name is Elizabeth Yerkes. I'm a pediatric urologist at Children's Memorial Hospital in Chicago, and today it's my pleasure to speak to you about surgical management of neurogenic bladder in individuals with spina bifida. Can I have my first slide? So historically, management of neurogenic bladder may result in what we call an incontinent diversion, where the urine would be diverted to a bag on the skin, and this would facilitate continence and to some degree would also protect the kidneys. Nowadays, we prefer not to think of incontinent diversion, and today we'll talk about the contemporary surgical management of neurogenic bladder in spina bifida. You may remember from the medical session on neurogenic bladder that there are several goals of therapy, and the goals of medical and surgical therapy are actually pretty similar. Our first job is to protect the kidneys, and our second and third jobs also are to protect the kidneys. After that, we'd like to help provide social continence, if desired, and help facilitate independence with the bowel and bladder programs. My job as a urologist is to interpret the many faces of neurogenic bladder, and this can be challenging at times, but the bladders may range from smooth and low pressure to something intermediate, where perhaps the bladder is becoming a little bit stiff or has a small capacity or borderline pressure, to an end-stage bladder where there's high pressure and clearly changes in the bladder wall. Just to review the medical management of neurogenic bladder and spina bifida, there are a number of contributions that actually still are important in our surgical management as well as medical management. In the 1970s, Dr. Lapidus introduced the concept of clean intermittent catheterization and introduced anticholinergic medication to manage the bladder. In the 1990s, Dr. McGuire helped us understand the pressure threshold above which there can be damage to the kidney and also damage to the bladder wall. And this magic number is 40. We'd like to keep the pressure in the bladder below 40. So when we talk about achieving continence with medical management of neurogenic bladder, specifically in individuals with myelomeningocele, less than 10% will be dry without catheterization. 60 to 70% will achieve satisfactory daytime continence with catheterization and anticholinergic medication. And the remaining 20 to 30% will require surgery in order to achieve dryness. It's that group that we'll focus on today. So why would we ever consider surgery if there's medical management? There's a couple of reasons. First, if we fail to maintain safe bladder dynamics or fail to be able to protect the kidneys, or if there's a desire for improved continence beyond what medical therapy can offer, or if we'd like to facilitate self-care in an individual who may have difficulty accomplishing the program on their own. So let's talk about our goals for reconstruction. Options and decision-making in the process. The short and long-term concerns associated with surgical procedures. And we also should consider alternatives to these procedures. And I'd ask you again to tune in later to Spina Bifida University for additional episodes on this topic. So our goals of reconstruction, as I said, are very similar to the goals for medical management. We need to protect the kidneys, we want to provide social continence, and we should facilitate self-care and independence to as great a degree as possible. So the mechanics of reconstruction falls into two categories. The first is that dealing with the bladder and how it holds the urine. First, we need to increase the size of the bladder if the bladder is too small. We want to decrease the pressure at which urine is stored in the bladder. And finally, we want to enhance the outlet or the drain at the bottom of the bladder to hold urine in. So in summary, we want to make the bladder bigger, better, and stronger. The second part of the mechanics is allowing a way for the urine to reliably leave the bladder. This can be done either through the urethra, as it's done with intermittent catheterization, or via a surgically created continent channel. We also want to consider management of vesicoureteral reflux, or backflow of urine into the kidney if that's present. So how do we as surgeons decide what you need, and how do we maximize the results without taking any unnecessary risks? Well, that's a great question, and that's where the art of medicine and science blend together. So first we look at the Aerodynamic Study, or the special test of bladder function. We're going to look at whether there's any changes in the kidney or hydronephrosis that would suggest that there's high pressure in the bladder. We want to look at the pattern of incontinence experienced by the individual who's considering surgery. We want to look at his or her ability to catheterize through the urethra. We want to look at the presence of vesicoureteral reflux, so again, backflow into the kidney. And we also want to consider where we are with the bowel program on a maximum medical program. Have we achieved consistency in continence or not? So this is an example of a urodynamics, or of a couple of urodynamics tracings. The patient on the top, you can see, has a relatively flat pressure throughout most of filling, but then the pressure steeply rises toward the end of the study. And this is a somewhat high-pressure situation and may be unreasonable for this patient to protect their kidneys over the long run. This patient's a little bit different. The pressure, again, is flat, but there's blips on the curves, which are contractions of the bladder that result in leakage from the bladder, and this impedes continence. How we treat those two patients will be different. This is an ultrasound that shows dilation of the ureter, or urine within the ureter behind the bladder. And this is the kidney image. You can see almost like a bear paw within the kidney. That's urine retained in the kidney, or hydronephrosis. And again, this is a sign that there may be high pressure within the bladder that's being transmitted to the kidney. When we look at an individual's experience with continence, we're looking for specific information on a day-to-day basis that we can correlate with what we see on the urodynamics test. We also want to know, are you wet early after intermittent catheterization? Are you wet only if you're late with catheterization? Are you more wet when you're more active? And will you have a squirt of urine with laughing, coughing, or walking? When considering whether a catheterizable channel may be beneficial as part of the surgical procedure, we want to consider whether self-catheterization is being accomplished. This may be limited in some individuals due to hand dexterity or due to flexibility they have in the hip joints that limit their access to the perineum. We also want to consider whether the planned surgery could change access to the urethra. For example, if we tighten the base of the bladder, that may make catheterization in the conventional fashion more difficult. And the last thing we want to do is get rid of access to the bladder. As a surgeon, we also want to consider the feasible stoma sites. So a place where we'd have the channel on the abdomen. And this will differ from person to person and may change depending upon whether you're standing or seated in a chair. We want to consider reflux. Is the reflux high grade or significant? Does the reflux only occur at high pressures? And what role does the reflux urine play in the basic urodynamics? This will help us make our decision as to whether surgical therapy is necessary. So in terms of the bowels, how satisfactory is medical therapy? Have we used time toileting, oral medication, digital stimulation, suppositories, and/or an enema program with good success or not? And does the individual have the dexterity to perform this program by themselves over the long run? So our components of surgical therapy would include bladder augmentation, potentially would include bladder augmentation, an outlet procedure to tighten the neck of the bladder and provide continence, a continent catheterizable channel, a Mace procedure, and ureteral reimplantation. We're going to go through each of these separately. So in terms of bladder augmentation, this is also called enterocystoplasty, and this literally is taking a piece of intestine, separating it from the rest of the intestinal tract, opening it up, and putting it on as if it's a second story that's being installed in the house. For this, we most commonly use small intestine due to its properties, but also may use colon, or in some individuals, a piece of stomach. Ureterocystoplasty is when we use an existing dilated ureter that may be considered spare and apply that to the bladder for extra capacity in the bladder. An auto-augmentation is literally stripping the muscle from the top of the bladder to allow a diverticulum, or outpouching, from the dome of the bladder, also increasing capacity in some cases and lowering pressure. Finally, a seromuscular auto-augmentation is performing an auto-augmentation but stripping away the lining of the intestine prior to applying it to the bladder. So with any surgical procedure, we have to consider the pros and cons and potential complications. So pros in terms of bladder augmentation, or making the bladder bigger, would be that we increase the capacity and we decrease the storage pressure within the bladder, therefore letting more urine be held more safely. The other advantage of bladder augmentation is that the results tend to last over the long term. So this is a procedure that for most individuals would only be required once. The disadvantages of bladder augmentation are the long-term issues associated with putting intestine or bowel within the urinary tract and letting the urine mix with that intestine. Also, a disadvantage, but very necessary, is the need for meticulous long-term care of the bladder. So this is what I might consider an end-stage bladder. You can see that the bladder wall is very roughly or trabeculated, and there's reflux or urine going up into the kidney. And although we don't have a urodynamics here shown for this patient, we get the impression that this is a high-pressure situation. And this would be confirmed by urodynamics. This is what the bladder might look like from the inside. This is a view through a cystoscope where we've placed a light into the bladder through the urethra and taken a picture of the inside of the bladder. And you can see that it looks like there's a highway of bands that run across the back of the bladder. And this is built up scar tissue within the wall of the bladder. It's called trabeculation. And this is the thickened bladder wall. Usually the bladder is only a few millimeters thick, but again, the scar tissue has been built up within it, making the bladder wall stiff. So in these cases, we need to make the bladder larger in order to make things safe. So as I mentioned, we take a piece of intestine. The intestine is opened, and then we sew it into a patch, preparing it to sit on top of the bladder. And the bladder is opened like a clamshell in order to accept this piece of intestine. This is the patch. It's quite large after it's sewn together, and it's now prepared to become part of the bladder. And this is what the bladder would look like after the intestine has been sewn on. This is the edge of the intestine. It looks a little bit heart-shaped when we first finish. But as the bladder is asked to store urine, gradually over the next several months, the bladder will take a more oval or round shape. Augmentation comes with a lot of baggage, as we said. There are pros and cons of the procedure, and in some individuals there really is no choice if the kidneys are at risk. But the important thing to know is that it does work. So we have the preoperative image on the left, and on the right, the augmented segment is outlined in blue. And the stars show where the augmentation segment has joined the native bladder. And this is the same patient, so you can see that just by relieving the pressure, we've seen an improvement in the contour of the native bladder. It's not as roughly anymore. The other thing to note is that the neck of the bladder is no longer open. It was open before because of a high-pressure situation, and now with low pressures in the bladder outlet is closed during filling. So this can improve continence as well. This illustrates where a catheterizable channel may come into the bladder. So there's a number of complications that come along with any surgical procedure, and my job as a surgeon before one of these procedures is to make you as aware as possible of every potential complication, in the process likely scaring you, but it's important that you be informed about the procedure. So there's a number of short-term complications. One that will be especially important to many of you is the exposure of the VP shunt. So things that can happen in the short term after surgery, so meaning the first couple of months, weeks to months after surgery, would be that we could have a malfunction of the catheter that resulted in a bladder leak. We could have a bowel obstruction, meaning the intestine gets stuck together, and that occurs in about 10% of abdominal procedures. We could have an infection in the abdomen, or we could have a urinary tract infection. We could have breakdown or infection of the incision, the wound. You could have an infection or a malfunction of the shunt, and this occurs in less than 10% of patients after a reconstructive procedure. Or you could have persistent incontinence, particularly for the first several months after surgery. So what are the long-term concerns? These are the ones that are probably even more important to you. As I mentioned, the main concerns come with placing a piece of intestine within the bladder and having that intestine mix with the urine. We have to keep in mind that although we've separated the bowel from the intestinal tract, it still is bowel. It has its own blood supply and functions the same as bowel. So it can cause by exchanging by exchanging salts across the intestinal membrane, we can result in a whole body excess of acid that the body has to take care of. The bowel also makes mucus, which can clog up your catheter and interfere with normal draining of the bladder. The amount of acid that is produced depends upon the amount of time that the urine is in contact with the intestine within the bladder. So there would be less likelihood of creation of excess acid in the body if the bladder is emptied in a timely fashion every 4 hours. But if one were to choose to empty the bladder only every 8 hours, then there would be a higher likelihood of more absorption of these salts. Mucus is problematic, as I mentioned, in that it clogs up the catheter, but also sets one up for stone production within the bladder. So getting that mucus out on a regular basis is essential. What we mean by irrigation is that postoperatively, every day, forever, after the bladder is created, you'll drain the bladder and hook a syringe on and flush fluid in and out, trying to stir up and draw out that mucus so that it doesn't cause any problems. And that's, again, once a day, forever. Mucus also can contribute to urinary tract infections because bacteria hides within those folds, and as I mentioned, can result in incomplete emptying of the bladder, which in turn can result in urinary tract infections. And finally, stones. The mucus and the bacteria work together along with the stagnant urine to create stones within the bladder. This is an example of an excessive amount of stones that might occur after a reconstructive procedure, and this is what they look like in person. So there are a number of long-term concerns that are more of a nuisance, like mucus or the acid production. But there are two concerns, or there are two complications that are of particular concern to us, and this would include spontaneous perforation or rupture of the bladder and the risk of tumor formation within the bladder. Both of these can be extremely serious and something that we give great consideration to whenever we're considering bladder augmentation for a patient. So spontaneous perforation, as I mentioned, is an actual rupture of the bladder. This is the margin of the bladder itself. This is a catheter within the bladder. There's a little bit of contrast that's being put in during a CT scan, and you can see that some of that contrast is all out here lining the intestinal cavity, and a little bit here actively seeping out of the bladder. And if urine is outside of the bladder, then that urine is bathing the intestine and is bathing the VP shunt, and this can obviously result in some pretty significant complications. One of the problems is that reconstruction often is performed in individuals who have limited sensation within their belly cavity, and so the perforation may be present for a day or more before the diagnosis is made, so you can get quite sick during that period. There can be contamination of the VP shunt, which would likely result in externalization and replacement of the shunt and the associated complications. And in most cases, this is something that requires an urgent operative repair of the bladder. The cause is not well understood, but we believe it's due to chronic overdistension of the bladder, that is, not taking care of the bladder as you're supposed to on a regular basis and not irrigating out the mucus. Catheter trauma and abdominal trauma are rare causes of bladder perforation. So tumor formation within the bladder is obviously something that should concern you. It certainly concerns me, and there's been a lot of work looking at the incidence and risk factors for tumors recently. This is a picture of a tumor formed on the surface of the intestinal segment of an augmented bladder, and it's been removed in this case. The initial reports that brought this to our attention were all advanced stage tumors, and our goal should be to find tumors at an earlier stage so that they're treatable. This seems to be due to mixing of urine with the bowel segment, possibly the presence of chronic irritants like mucus within the bladder. And we found that the tumors tend to occur after many years, even up to 10 or more years after the procedure. The newest data has given us a little bit of comfort in that it shows that there's only a few % lifetime risk of tumors within an augmented bladder. And as it turns out, for most individuals, this risk is similar to performing clean intermittent catheterization over a long period of time alone without bladder augmentation. So our prevention strategies in terms of preventing these two long-term complications would be sticking to a strict intermittent catheterization schedule. We want to catheterize by the clock and not by sensation of fullness or by the amount of fluid that's been taken in. We want to irrigate the mucus daily to wash that out and prevent stasis and irritation. And many recommend performing a yearly surveillance cystoscopy or a look within the bladder beginning 5 years after surgery. And there's some debate as to whether this is cost effective, and it's not clear whether this will become a long-term recommendation. So let's move on from bladder augmentation to talking about outlet procedures for the bladder. So again, these are procedures to tighten up the base of the bladder or the drain at the bottom of the bladder to facilitate continence, to help you store the urine. There are several different types of bladder neck procedures. One would include a bladder neck sling, or a piece of your own tissue that's wrapped around the base of the bladder to cinch it tight. A bladder neck reconstruction, where we tubularize the bladder neck structures to make them more narrow or more tight. an artificial urinary sphincter, which is a artificial apparatus that's put around the base of the bladder and is manually controlled by a pump. And finally, bladder neck closure. And I put this well down the line because this would be either for redo or highly complex cases. So the goal of bladder outlet procedures, regardless of the type, is to tighten the base of the bladder to facilitate storage within the bladder. So here you can see on VCEG that the bladder itself is relatively smooth-walled, but the base of the bladder is open, like a funnel, letting the urine come out. The goal of the bladder neck procedure is to tighten the base of the bladder. So what you should know about bladder outlet procedures is, regardless of the procedure, we're still looking for the perfect one. The success rate of bladder outlet procedure alone is less for achieving continence than when combined with other procedures, because again, it's not perfect. About a third of bladders who seem to only need an outlet procedure for continence will subsequently deteriorate, and that means that once we've asked them to store urine on a regular basis, they aren't able to take on that challenge, and the bladder wall becomes stiff and there are high pressures. So these are individuals who we need to watch carefully, as they may need a bladder augmentation after all. Catheterization may become more difficult or risky or unreliable after a bladder neck reconstruction is performed. And so our current recommendation is to place a continent catheterizable channel in combination with bladder neck reconstructions. So what is a continent catheterizable channel? You may have a number of questions. I really think this is one of the best things that we do, or best innovation that we've had in pediatric urology, because it really does allow individuals to care for themselves in situations where they previously weren't able to. So what is a channel and why would I need one? Where will it be? What will it look like? Will I have to wear a bag? Can I swim? And can I cath anywhere? These are all good questions. So first, what is it and why would I need it? So a continent catheterizable channel comes in a couple different forms. The principle of the catheterizable channel is called the Mitrofanov principle, because the initial channel in appendicovesicostomy was developed by a French physician, Dr. Mitrofanov. The concept of continent catheterizable channels is to allow reliable catheterization of the bladder, or reliable emptying of the bladder, via a route other than the urethra. This facilitates independence. It's convenient, it can be done anywhere, and it provides trustworthy access to the bladder, particularly in the setting of a bladder neck reconstruction. If we can combine the ability for independence with convenience, then we're much more likely to have compliance with the bladder program. The question you may have is, will a channel make me dry? That's a great question. Placing a continent catheterizable channel alone changes only the route for intermittent catheterization. It does nothing in and of itself to facilitate continence. It may make you drier if it helps you cath on time easier. So meaning if you have better access to the bladder, it's less troublesome to get into the bathroom and empty the bladder, then quite likely you would be drier. It will not create continence if the bladder is unhealthy or if the bladder outlet is weak. You would require additional procedures such as a bladder augmentation or an outlet procedure. So this is a picture of the appendix being prepared for an appendicovesicostomy. So the circle here is drawn around the appendix. We've made a hole at the base of the appendix, separating its blood supply from the rest of the colon. And we actually will separate the appendix here from the colon and oversew the colon and prepare the appendix to become the channel. So this is an intraoperative photograph. Here is the appendix opened up with a catheter in place. And here it is tunneling under the back wall of the bladder, and you can see it here peeking into the inside of the bladder. So literally we're forming a tunnel through the bladder wall, and that's a continent space. So when the bladder fills, it compresses the channel, and there should be no leakage out through the channel. This is a more up-close view of the same tunnel principle. That's the channel outlined, and that's the channel tunneling underneath the wall of the bladder. That end will come up to the skin to be the stoma. So this is a schematic side view of a Mitrofanov. So here is the appendix, here is the blood supply to the appendix, and here is the bladder. And you can see that the Mitrofanov is coming down, tunneling under the bladder wall, and entering here. So this is the continence mechanism. When the bladder is full, it compresses the channel. And when a catheter is passed, the bladder is siphoned out or drained from the bladder, and the catheter is removed, and you go about your business for the next several hours. So what happens if the appendix isn't there? Some people have already had an appendectomy, or they have a small, thin, stubby appendix that can't be used for reconstruction. Well, several other clever surgeons have come up with an alternative to this problem. So this is an example of a Monti-ileovesicostomy, where a small piece of intestine is taken and is opened up and rolled into a tube in the opposite direction. So essentially we're creating a new appendix with its blood supply here in the center. So we have one end to put into the bladder and one end to bring up to the skin. Operates on the same tunneled principle. So we can use that Monti-ileovesicostomy. We can perform a continent vesicostomy, which is a bladder tube utilizing only the bladder tissues. We could use ureter if it were available and not being used to drain the kidney. We could use fallopian tube if it could be spared. It wouldn't be used for the uterus anymore. Or newer reports have suggested developing a subcutaneous skin tube that wouldn't involve any intestine at all. So where will the stoma be, and what will the stoma look like once it's all healed? So the stoma could end up in the umbilicus or the belly button, and that's our preference if it can be safely placed there, or it could end up on the right side of the abdomen. Your body really determines the site in which it'll be placed. How large the bladder is and how long the appendix is play a role in that decision. What we really need to do is put it where it will work. If we put it somewhere where you can't reach it, or where its blood supply might be compromised so that it scars shut, then we haven't done you any favors during this reconstructive procedure. So what will it look like? Well, to be honest, early on, it doesn't look so great. It can look kind of bloody and scary and swollen. The final stage varies from person to person. It varies by the site in which it's placed. It varies by your body type and your innate healing process, as well as any potential early surgical issues. So this is an example of a young lady who is about 3 weeks out from surgery, and you can see she has, you can't see, she has one stoma concealed in her belly button, and she has another stoma here in the right lower quadrant. She's got the sutures still around the edges, and these are marks from where the catheter was sewn in place that's recently been removed. This is an up-close view of the stoma. This is the same young lady 6 months later. So in this case, the wounds have healed to form a scar around the stoma, but the stoma itself is a small pink hole. You can see here a quarter for frame of reference. Again, to emphasize that they look different in each person. So this is a channel that's hidden in the umbilicus, hidden here in the base of the belly button. Here's a scar right at the belt line, it's a stoma at the belt line with a surrounding scar, but widely open. And this is an individual whose stoma has gotten a little bit tighter, has developed stenosis that we've had to dilate so that she can access the stoma. So again, everyone heals differently. Some people develop more of a protuberant-looking stoma that sometimes weeps fluid because it's a piece of intestine and it's easily irritated. And some people form thicker scars or hypertrophic scars. In others, the stoma can be concealed nicely within the belly button, sitting right here. So other questions you may have. Will I have to wear a bag over the stoma? No, it's meant to be a continent stoma. In some cases, there can be a little bit of mucus that drains from the stoma, and so some people choose to wear a Band-Aid over it. But for most people, they just go plain skin. Can you swim? Absolutely, once the healing process is complete. And can you catheterize anywhere? Yes, anywhere where you have a place to collect the urine, you can catheterize. You can do it in the back seat of the car. You could do it on the playground, really anywhere that's convenient. So let's talk about complications. Just like there are complications of bladder augmentation, there's a set of complications that you should be aware of that go along with continent channels. The first would be stenosis. Remember the one young lady who had a tightened area at the skin, and this is a narrowing or an overzealous healing that occurs of the stoma, or perhaps the blood supply at the tip of the stoma isn't adequate, and so a scar develops. Historically, these have been managed surgically when you're no longer able to access them with the catheter, but now we're able to passively dilate them and achieve good results without surgical intervention for most. This occurs in approximately 20 to 30% of channels. You can have difficulty catheterizing the channel, so difficulty getting in either at the skin or further down the channel, and this is particularly problematic when the bladder is allowed to over-distend because this results in some kinking of the channel, and you may be butting into the back wall of the channel as you're trying to pass the catheter. Next, we can have a false passage, which means the catheter got lost on its way into the bladder, or you may develop a stricture within the channel. In rare cases, there will be leakage or backflow of urine from the channel. And one complication of all catheterizable channels is that we're now siphoning the urine from above rather than draining it through the urethra, so rather than draining it dependently. And so there's a slightly higher risk of incomplete emptying of the bladder that may increase your risk of urinary tract infection. So bowel programs are something that families often struggle with to achieve consistency and continence. And the Mace procedure is how we can help achieve continence in those individuals. So keep in mind the challenges with the bowel program center around the fact that there are different needs for different colons. The sphincter tone may be high or the sphincter tone may be low. Those who have low tone may have incontinence with or without constipation, and they may have loss of stool with activity or laughing. Those who have a high tone are more likely to have constipation, but they may also have incontinence as well that we need to deal with, and they may require stimulation to get the stool out of the colon. So this is an example of an individual with Spina Bifida who has a VP shunt. You can see the shunt here snaking through the belly, has some scoliosis or curvature of the spine, and you can see lots of balls of stool here within the colon. I'll line up some of them for you here. So you can imagine that if all that stool is sitting there and the stool that's up above gets a little bit impatient and wants to find a way out, that stool will find its way around. And so in an individual who's profoundly constipated, if we give them laxatives, they often will have run-around loose stools, still leaving behind the impacted stool. So for individuals in whom medical therapy has been completely exhausted and we don't have consistency or continence of stools, then we would consider the Mace procedure. This was developed by Dr. Malone in 1990, and the M is for Malone, but the procedure is called the antegrade continence enema, or ACE procedure. Studies have shown that there's a very high success rate with this procedure in terms of achieving continence and a high satisfaction level on the part of the patient and the family. The principle is that the channel would be catheterized at skin level, so it's another form of a continent catheterizable channel. And an enema bag is hung on a hook in the bathroom, and the water flows in. So this is giving an enema antegrade, or forward, so that the enema fluid carries the stool out through the rectum. So our options for an ACE would be to use the appendix as well. If it's the only procedure being done, then it's no issue. But if there's being a Mitrofanov, or if a Mitrofanov is planned as well, then we can potentially split the appendix and use it for both procedures, assuming that the blood supply to the channel is adequate. We can apply the Monti principle. Remember, that was the piece of intestine that we opened up into a tube to make a neo-appendix, and we can plug that into the colon to be used as a channel. We can raise a flap of colon and tubularize that to make a neo-appendix. And the final two options are appliances that would be placed on the abdomen. So the first is a Mickey button, similar to that used for a gastrostomy, where it would be uncapped and the enema fluid would be placed through it. And the other is a Chait tube, which is another button that's placed in a minimally invasive fashion by the radiologist, also allowing you to access the colon. But both of those always have an appliance that sits on the abdomen. The Mace continence mechanism is performed by imbricating or wrapping the colon around the appendix so that we kind of create a turtleneck or a sphincter around the appendix so that stool doesn't leak out. So this is an example of a Monti Mace. Here we've created that catheterizable channel. We've got the colon open, and the mucosa, or the lining of the colon here, is exposed, and the muscle is here, and we're going to wrap that around the channel to create the continence mechanism. You can see here the continence mechanism. So the ACE procedure also can be created on the left side, and obviously this would not involve the appendix since the appendix is on the right side, so this might be an option for someone in whom the appendix isn't available. It's a newer concept. What's involved is still an antegrade administration of an enema, but in this case it's put in on the left instead of on the right. The pros of this would be that less volume of enema fluid might be required, and therefore there's less time to evacuate the enema and potentially less cramping from distension of the colon. The cons of the procedure is that we can't use the appendix, and so we'd have to raise a colonic flap or perform a Monti Mace procedure or perhaps place a button. The individuals who are the best candidates for the procedure are those who have fecal incontinence or incontinence of stool associated with a very weak sphincter or open sphincter. It also may be useful in individuals who have the most severe constipation because there's less colon that needs to be cleaned out with the procedure. Therefore, there may be less pain and less time. So in practice, the stoma is catheterized. You can see it being placed here in the umbilicus, and the enema bag is hung. The fluid, you let the fluid run in. As soon as it's done, the catheter is removed, and then you would sit on the toilet for anywhere from 20 minutes to an hour to evacuate the enema. There are a number of different options. It can be as simple as using tap water from your house to salt water, or sometimes adding enema fluid or some other form of irritant. Things such as licorice root can be used if there's excessive cramping or pain associated with the enema. What should you expect from the Mace procedure? Well, you should expect a marvelous improvement in bowel function. However, you should not expect perfection. It's markedly improved, but some people will still have accidents, particularly when they eat a trigger food, like something spicy or fatty, or if they have a gastroenteritis or flu-like illness. Some people will still require oral medication in order to keep the stool soft enough for the enema to do its job, so it's not washing around it like the rocks in the stream we talked about. The daily time commitment could be anywhere from 20 minutes to 60 minutes. If it's longer than 60 minutes, likely we need a different program to help evacuate the bowel. The thing that's most important for you to keep in mind as you're planning the Mace procedure is that it can take several months to find the right recipe. Remember, different things for different colons. And that can be extremely frustrating if you were expecting an immediate good result. So we need to work together as a team to find the right recipe for each patient. Like every other procedure, there's complications associated with Mace. One would be that adding that fluid to the colon could have an effect on the salts within the bloodstream. If there's retained water or retained salt water or even the irritants and enemas, they can be absorbed by the body and cause problems. In rare cases, there also can be incontinence through the stoma. It could be incontinence of gas or incontinence of stool, but again, this is uncommon, and we have ways to manage that. Usually our first line is to suspect that that we're not getting a good washout from the stoma, and we need to do a better job evacuating the colon in order to achieve continence at the stoma. We also can have stenosis, just like we can with an appendicovesicostomy or the catheterizable channel for the bladder. This is perhaps more likely to occur with a Mace procedure because you're only accessing it once a day instead of every 4 hours during the day. And so what I typically will ask families to do is to pass the catheter twice a day to give the stoma a little exercise, but only provide the enema once a day. So minimally invasive surgery has become very sexy in all surgical fields, and that includes urology. And there are minimally invasive options or laparoscopic or robotic-assisted options for urinary reconstruction. And this includes bladder augmentation, creation of a Mitrofanov, a laparoscopic ACE procedure. Not everyone is a candidate for a minimally invasive approach. If there have been multiple abdominal surgeries, or if the body shape is such that the trunk is very short, then a minimally invasive approach may be frustrating for the surgeon and not provide a significant advantage for the patient. So we need to have adequate space within the belly. And what you should remember is that it is less invasive, yes, but it is still a major procedure where we're taking a piece of intestine and reconfiguring it. And the potential complications to the shunt, such as malfunction or infection, are still present even when this is performed in a minimally invasive fashion. So your recovery might be faster, but the procedure itself is really the same. So let's talk for just a minute about reflux. Reflux is backflow of urine into the kidney, and how we manage it will vary from patient to patient. Previously, whenever we're performing a major reconstruction, if there was reflux present, we would reimplant the ureters or give them a new tunnel within the bladder. We've recognized, though, that this may not be necessary in every individual and may actually increase the complications associated with surgery, and so we tend to take more of a tailored approach now. So we want to use our knowledge of the existing bladder dynamics and decide which ureters should be reimplanted and which ureters might resolve on their own after reconstruction. And if there are some that, some cases in which high-grade reflux persists several months after surgery, then we have the endoscopic bulking agents in our back pocket that we can use to treat the reflux in a minimally invasive fashion. So again, management of reflux is where we blend art and science in medicine to try to do the right thing for each patient. So if the reflux is deemed to be related to the bladder pressure, the high bladder pressure, then we would not typically reimplant the ureter. If reflux is high grade and doesn't seem to be related to bladder pressure, then in some cases we would reimplant, and in some cases we would go without and know that we could do the endoscopic injection. So now that we've talked about all the good and bad of each of the procedures, you may have some other good questions about surgery. So what is the best time for surgery? First thing we want to know when answering that question is the bladder, and therefore are the kidneys, safe given the current dynamics? Are we dissatisfied with the urinary or fecal control on a medical program? And are you ready to commit to a long-term maintenance that includes intermittent catheterization every day, every 4 hours, and irrigation of the bladder every day to care for the reconstructed bladder and bowel? Do I have to have all the procedures done at once? Well, if all the procedures are necessary for you, given your dynamics, then in general we feel that one trip to the operating room is better for you and for the surgeon. This allows for one recovery period and all that comes along with that, and allows us to operate on virgin tissue planes. That doesn't mean that we can't bring you back to add a procedure later if that's what you choose, but it is more difficult to accomplish at that time. So in summary, in appropriately selected patients, reconstruction can positively impact your continence and level of independence. We want to carefully consider the dynamics and options and individualize a surgical plan. We want to try to stay on as much on target as possible to limit the complications and limit unnecessary procedures. I'd like you to remember a couple things. So if the kidneys are safe, whether to do surgery or not is your choice, and you have my guidance along with that. If your kidneys are under stress, meaning that there's hydronephrosis due to a high-pressure bladder, then it's my choice. We really need to proceed in order to save the kidneys because the repercussions of remaining with bladder pressure would be irreparable damage to the kidneys and possibly kidney failure. So my obligation as a surgeon is to consider your clinical situation and what might be needed, and to provide the technical skills in the operating room, and then provide technical support after. You need to be prepared to handle complications and work through them until any complications are resolved. Your obligations are to be informed preoperatively, to know the potential complications and to know your situation. You want to make sure that your surgeon has experience with the procedure and that your surgeon has a track record of working through complications. Your obligation also is to follow all care instructions that the surgeon provides, because really you have to work together to provide a successful outcome from the surgical procedure. Other things to remember is that we look for we expect an excellent success rate, but there's no guarantee that continence will be achieved or that there won't be a complication. Some individuals quite simply need a second operation to take care of things. We want to keep in mind that the recovery period is not insignificant, regardless of whether it's performed in an open fashion or in a minimally invasive fashion. This involves incisional pain, pain at the stomas, the care required for the stomas and the bags in the first several weeks after surgery, and also time that may be missed from school. You should keep in mind that minor setbacks are very common after the procedure. Fortunately, major setbacks are not particularly common. And keep in mind that you might dislike your surgeon for a few weeks after the procedure, but typically you'll come around. So in summary, there are significant short-term complications are not common, but insignificant ones are fairly common after surgery. There is, however, that long-term baggage that we worry about in terms of complications, and these are most manageable if we're compulsive with self-care and surveillance of the bladder. There's a trade-off for the benefits of reconstruction. That is that we can give you preserved kidney function and continence, but you have to go through something to acquire that. Thank you.
Thank you for attending this session. Because meeting your needs is important to us, we need your feedback on this presentation. Please take a few moments to complete our evaluation, which can be located by clicking on the presenter's name located to the left on your screen. It will only take a few clicks of your mouse to provide us information to make the SBU experience better for you and others. If you have any questions relating to SBU, please contact us at sbu@sbaa.org.